Welcome to a podcast brought to you by the American Academy of Orthopedic Manual Physical Therapists. Our academy is a national organization committed to excellence in orthopedic manual physical therapy practice, education, and research, and we're here to explore a wide range of topics with you through interviews with content experts.
Hello, my name is Stephen Shaffer, and I'm excited to bring to you another spectacular interview. Today's guest is Dr. Lance Mabry. Dr. Mabry earned a doctorate in physical therapy from U.S. Army Baylor University. His clinical experience has been focused on outpatient orthopedics, though he also has extensive experience in both acute care and emergency department settings. He serves as a member of the APTA Imaging Special Interest Group Nominating Committee, as the APTA of North Carolina Triad District Vice President, as the APTA Key Legislative Contact for North Carolina District 13, and on the APTA of North Carolina Legislative Committee. He is currently also an associate professor at High Point University, and let's just say he has dozens of professional accomplishments. We invited Dr. Mabry to the podcast because he was recently the primary author of an article published in the Journal of Manual and Manipulative Therapy titled, "Physical Therapists are routinely performing the requisite skills to directly refer for musculoskeletal imaging and observational study." In part, this interview will be a continuation of a prior theme we discussed with Dr. Charles Hazel at the 2019 AAMPT conference, which we recently rebroadcast in August of 2022. If you haven't listened to that interview recently, then I'd recommend checking it out as an adjunct to what we're talking about today. Also, if you like what you hear today and you'd like to learn more from Dr. Mabry, he teaches clinical application of diagnostic imaging through Redefined Health Education. Exclusive for AMP podcast listeners, you can find a coupon code good for $50 off their imaging certification course in the show notes. Those points aside, this conversation should be informative and interesting, so let's avoid any further delay and get to the interview. Dr. Mabry, welcome to the podcast. How are you today?
I'm doing wonderfully. Thank you so much for having me.
Well, we are excited to have you here today. This paper was particularly interesting to read, and it fits in really nicely with a general conversation that we have been having and will continue to have on the podcast. And speaking of that, let's start things off by asking a really big question. Within our healthcare systems, what are we currently doing well with respect to imaging, and where are we getting things wrong?
Yeah, I think that's a great question to start us off. And I think a good portion of that comes kind of from understanding the history of diagnostic imaging and how we got to where we are currently. I saw a presentation by Lynn McInnes on the history of diagnostic imaging, and it was really helpful to kind of get a good feel for where we are in space. So, radiographs came on in largely the early 1900s sometime. And with the advent of that, there was introduction to x-rays in shoe stores. And, kids were going in there. And if you want to know if your shoe fits, we'll x-ray your foot. And things really got out of control as far as imaging. And even you look back at, the TV show Scrubs back in the 90s, which wasn't that long ago. There was an episode on, the hospital got a CT scanner and they were going to do a full body CT scan. They were selling them just if people wanted to buy a full body CT scan. That's what they did. So, the overutilization of imaging, while we have a history of it, the history is not necessarily all too distant. It's been reasonably recent, but I think we're almost on the opposite end of that now. I think that the pendulum has swung so far to the imaging doesn't matter side that a lot of the evidence that's coming out there has, an inherent bias underlying it. So, you look at a lot of these studies that look at imaging findings in asymptomatic patients, and they never compare it to symptomatic patients. And when they do, those aren't the ones we tend to talk about a lot. We tend to talk about only the asymptomatic ones. So when you look at the history of the research, we've been hearing a lot about asymptomatics, and it's reasonably rare for these studies to, include symptomatic comparisons. And it really ends up, the literature being overly biased against imaging. And I think we need to find that sweet spot back in the middle where we're not using imaging when it's not indicated or when it's not appropriate. We're not over irradiating patients that don't need it, but that we do feel comfortable in ourselves and in our practice to utilize imaging when it is appropriate and when it is going to change practice and it is going to change the management of that patient.
Thank you for that. I think it's a great answer. And I really love the point essentially about being effective and efficient, which is what I think we learn when we go through fellowship training. We want to use whatever technique or technology or treatment is warranted when it's actually, needed for that patient. And then we don't want to use it when it's not warranted. That, of course, is the best way to deliver healthcare and make sure we all get what we need and we're not wasting resources.
Yeah, I agree with that completely. I believe, the misnomer of diagnostic imaging is that it's diagnostic in nature. And while diagnostic imaging can be used for diagnosis, a lot of times in physical therapy, that's not what we're using it for. So it's almost sides of this, the imaging doesn't matter side versus the imaging matter sides. And, those on the, imaging is irrelevant side will say things along the lines of, well, diagnostic imaging doesn't matter because I can diagnose all on my own. Those of us that are in this space of diagnostic imaging, I look at, the Mike Rosses and the Aaron Kyles and the Mike Crowells and the Don Gosses. And, we can all diagnose too. That's not what we're using imaging for. And a lot of times it's, for patient management where, the patient has, I did a study with John Tonarelli years ago on an Achilles rupture. And, yes, we did the Thompson test. We knew it was an Achilles rupture. The person couldn't heel raise. I knew it was an Achilles rupture right off the bat, but, being able to order that imaging and set things up for them. So when they walk through the door at orthopedics, they have all the imaging they need, and then they could just make a decision on, whether or not they were going to treat it surgically or otherwise. It really eliminates a lot of the extra steps that patients need to go through. It eliminates the redundant encounters. It reduces healthcare utilization. It reduces the co-pays for the patient in a civilian population. So there's a lot of value to imaging that isn't necessarily diagnostic in nature.
And one of the interesting variables at play, which you've just begun to touch on in that answer, is that different providers have different skill sets and play different roles when it comes to at what point are they interacting with the patient. And speaking to that point, how is the current healthcare landscape similar with respect to physicians and physical therapists when it comes to ordering musculoskeletal images specifically? And perhaps a more important point, how is it different between these two different professions?
Yes, that's another great question. And you asked me to start off with how is it similar? Right now, there are 10 states that allow physical therapists to refer for imaging explicitly, either in their Practice Act or their board rules. I'm going to do my best to rattle them off from memory, but Wisconsin, North Dakota, Rhode Island, Utah, West Virginia. Did I say Colorado already? Maryland, DC, I think New Jersey. I don't know if that's all 10. And those that have passed it through either board rules or through board decisions have the ability to refer for both x-rays and MRIs and any other imaging modality needed, just like, both physical therapists and presumably physicians can do that. Some states, primarily the ones that have passed it through legislation, so we're talking Wisconsin, North Dakota, Rhode Island, and I think Arizona, only allow physical therapists to refer for radiographs at this point. So that's a little bit different than what physicians have available to them. I would tell you that what I've seen as far as differences is when physical therapists are referring for imaging, usually we're the ones that are placing it into the EMR or writing the script or whatever else ourselves versus the primary care providers. A lot of times they're passing that off to their med techs. So they're seeing a patient and they'll, tell their med tech, hey, can you put in a knee x-ray for patient Bob that I just saw? So the difference with that is when the provider's putting in themselves, a lot of times the referral that's going to the radiologist tends to be a little bit more robust. So the radiologist can give a little bit of a better reading versus a lot of times when it's going through an intermediary, such as a med tech, a lot of times the radiologist is only getting a history of something like foot pain or back pain, but is not getting any of the contextual factors. So that's certainly a difference. Oh, one similarity that I missed, was that both primary care providers and physical therapists in those states that allow or refer for imaging are not having any problems with getting imaging reimbursed. So that's a common concern that physical therapists have is if I refer this patient, will it get reimbursed? Are there problems with that? The Kyle et al. Study touched on that. I forget which year that one was. Then there was also a study that the president of the Wisconsin chapter put out, Connie Kettleson, and they looked at that as well. And essentially what they found was physical therapists are concerned that imaging isn't going to be reimbursed, but when they're actually asked if they had any problems getting reimbursement, none of them were actually reporting any problems. So it seems to be one of those where the fear of the reimbursement seems to be greater than the reality of that. And in talking to different radiologists that are working in imaging centers or imaging center owners, they're a lot of times thrilled to have the referral source. Now, getting back to what some of the differences are. So when we look at, evidence-based guidelines, you talk about the American College of Radiology appropriateness criteria, things like that. And when you're starting to look at whether or not an image is appropriate or not, one of the things we're hearing a lot in this space is that imaging is overutilized. And that is actually a little bit of a misnomer. Imaging is overutilized, but that's only part of the story. And if you look at the Jenkins et al. Article from Spine Journal, they looked at both patients that received imaging, and then they also look at patients that aren't receiving imaging. That's that other side of the coin. Their stats were a little confusing, so it's hard to understand if 2/3 were appropriate or only 1/3 were appropriate, but essentially somewhere between 1/3 and 2/3 of patients that received imaging didn't need it. So that kind of gets back to that overutilization. So patients are getting imaging that's unnecessary. But the interesting thing that they did in theirs was looking at those that didn't get imaging, and those that didn't get imaging but needed it because they had, a red flag or there was concern for cancer or something like that. 2/3 of those patients didn't get the imaging. So in that case, you could call it underutilization. So when you look at those two things together, you can't really say overutilization. You can't really say underutilization. What you really need to say is imaging is being misused. And one of the primary reasons for that is that the responsibility is falling right now in the laps of the primary care providers. They're phenomenal at what they do, but they don't have a whole lot of training in musculoskeletal medicine. Some of the research out there says 8 to 16 hours in some of these programs in musculoskeletal medicine. So it is their responsibility to make these decisions, but they don't have the educational grounding to do so. So in those that are saying things like, oh, well, I think it's overutilized or it's not being utilized properly, that should be one of our biggest pushes to say, well, yes, the responsibility should be shifted to us. We do have the education in this. We do have the training. We do know when it's appropriate or inappropriate. And that shakes out in the research. Again, if you look at that Jenkins study that shows primary care providers roughly 66% appropriate, and then you compare that to the Kyle et al. Studies, the Crowell et al. Studies, depending on how you want to look at the Moore et al. Study, tends to be in those high 80s to low 90s% of appropriateness from physical therapists. So when we're ordering it, we're ordering what needs to be ordered, and we're not ordering extra imaging.
Thank you for that excellent and thorough response. I have a couple of quick little things. First, forgive my ignorance, but I did not know that in the United States, there were 10 states that already allow physical therapists to refer to musculoskeletal imaging, even if it is limited in some jurisdictions. My prior notion or idea or understanding was that it was only the U.S. Armed Services. So I'm pleased to see progress in that regard. And actually, at present, as listeners most likely know, I'm living and working in Canada. And here in Ontario, the province of Ontario, we cannot order imaging, but it's one of the current goals that our provincial organization appears to be working on. Because just like you said, and that was, two great points in a row, we're potentially misusing imaging as opposed to overutilizing it, which speaks back to my prior statement about being effective and efficient. And that's the same tact that they're taking here. We have the education, like you said. Even entry-level physical therapists have more orthopedic or musculoskeletal education, which sets us up, even when we're not confident about it, to be better orderers of images. And then you start to look at the individuals that are residency trained, fellowship trained, or doctoral trained in orthopedics. And I think physios in general are doing a really good job at this. And personally, in my clinical practice, I've had some really interesting encounters. One that popped to mind while you were talking was a conversation I had with an orthopedic surgeon about the patient, and we actually pulled up the imaging and we were talking all these different variables. And they seemed to be a little bit lost and confused and literally used the phrase, well, this is like the blind leading the blind. And he was essentially saying, and that's actually probably derogatory towards the blind, who would probably do a very good job at leading each other. But the point that he was trying to make was a physio and an orthopedic surgeon, meaning a non-radiologist and a non-radiologist, have no business figuring this out. But like you, I happen to have some training in radiology, and I was able to use a certain method, the ABCS method, and read the imaging to him and look at the different features and try to figure out what was going on with the patient as it related to the clinical exam. But I think it's just one little, tiny story that conveys how in that scenario, and likely based on all the other evidence in many other scenarios, we are ready for this role. We just have to step into it and demonstrate how good we can perform in this part of clinical practice.
Yeah, I think you have a couple of great points there. We looked at, I did a study, I published it, I want to say in 2020 in Physiotherapy Research International, and I was looking at which nations, as part of I think it's World Physiotherapy now, but it used to be the World Confederation of Physical Therapists, which nations allow imaging. And one of the countries we reached out to is Canada. And I think they did say that Alberta now allows for imaging referral, but that there were other provinces that were looking at it and expanding it. And it sounds like Canada has a very parallel pathway to what the United States is doing now, where they're doing it state by state or province by province. So good luck with that journey. I think it's what the patients need. It's what the healthcare system needs to expedite care and also to reduce healthcare utilization. The second part you talked about there, as far as, looking at imaging, and you were talking about looking at it as a physio and looking at, the orthopedic surgeons looking at it. One thing I will say is that while physical therapists or physiotherapists, while we're not radiologists, nor are orthopedic surgeons, and radiologists are the absolute best at what they do, I do believe there's a lot of value to us looking at imaging as well. We have the patient in front of us. So while we're never going to be radiologists and we're never going to be as good as them, the radiologist's eyes alone are never going to be as good as the radiologist's eyes plus our eyes together on that image. So every patient that walks through my door, I'm looking at the imaging. Everything I request, I'm looking at the imaging. I'm looking at it. And the majority of the time, what I see is exactly what the radiologist sees. Sometimes I see something that I don't understand and I'll have to reach out to the radiologist, and it's more of a learning point for me. But on rare occasion, there are some things that the radiologist misses, and it's not their fault. They're humans just like anybody else. And in that case, just having that second set of eyes to look at it has always been welcome. And one of the things I found is that radiologists really embrace the clinician reaching out to them, assuming it's not overbearing. But, if you have questions reaching out, I think they appreciate the fact that this imaging means something and that people are looking at it and paying attention and want to grow into that space.
Those are all great points. Thank you for adding those. And while I think we could banter back and forth for a long time about imaging in general as it relates to clinical practice, I really want to get into the study that we invited you here to talk about today. And that is, you created a survey. You relied on a panel of experts to help make this survey. And in particular, I found it interesting that you discussed 9 different skills that you identified through this panel as being important for physical therapists when they're going to order musculoskeletal imaging. Can you briefly run through those skills and time dependent, et cetera? We don't have to lay out the whole paper here because we can link to it and people can go read it. But can you expand on these ideas a little bit and why in particular you thought these skills were relevant for our profession as it relates to orthopedic imaging?
This is a great question. And I want to start off by thanking my co-authors with for their assistance in the paper. This paper never would have come to fruition without all of their work on this. The idea behind coming up with a skills list for imaging referral was really grounded in trying to get legislators and boards the information they need in order to make decisions on whether or not jurisdictional scope of practice should be changed. And the idea that kind of drove this was this idea of, well, physical therapists are doing everything but. We're doing all of these things with imaging. We're deciding when patients need imaging, we're contacting the PCP as an intermediary if we're in a state that doesn't allow it. We're reviewing imaging with the patients, we're integrating it into our practice, and if things are showing up that we need to refer them out, we're doing all of these things. It's just that we can't pull the trigger on the imaging order itself. So it's more of an administrative block than anything. It's not as much a clinical block. And that was the idea, is basically showing we're doing all of it, just not ordering the image. And in order to show that, there are some responsibilities that come before the image is ordered. And then there's also some responsibilities with the imaging request or the order itself. And then there's some responsibilities that come after the image is ordered. And when you talk to legislators and board, the people on the boards, the rules makers that are making these decisions, these are the things that they're worried about when they start expanding scope. They want to make sure the public is safe. And these are the kind of questions that come up. So we came up with 3 different criteria that kind of happen before an image is ever decided to be ordered. And the very first one is triaging the patient, right? Does the patient even belong to you? So if they're having a heart attack, we're probably not going to order an image. We're probably sending them somewhere else. The second one we came up with was using evidence-based imaging guidelines. So once we decide that, yes, they belong to us, are we using guidelines like the Ottawa ankle rules, the Ottawa knee rules, the American College of Radiology appropriateness criteria to help guide us in those decisions? The third one is, after we use those, understanding the risk benefit in that patient individually. So every patient has a different presentation, and maybe in this particular patient, it might be indicated for whatever reason, but for this presentation in this patient, it may not make sense. Or maybe it's not indicated, but for this patient, for this case, for whatever reason, it might make sense. At that point, you should kind of make the decision of, yes, I'm going to pull the trigger, or no, I'm not. And if you decide, yes, we are going to order the imaging, our fourth skill was either referring for radiology or requesting through an intermediary. So a PCP, an orthopedic surgeon, essentially contacting somebody and saying, hey, we need an image. The fifth skill was, if we're going to contact somebody and say we need imaging, suggesting which imaging modality that'll be. Is it X-ray, MRI, things like that? And then after the image is ordered, the things that are required in order to maintain safe practice thereafter. So once the imaging is ordered, are you reviewing the radiologist's interpretation? Are we educating your patients on those findings? Are we integrating the findings into a management or treatment plan? And then lastly, and this is one that the rules makers tend to really pay attention to, if something shows up on that image that is not appropriate or not within your scope of care or requires somebody else to be tapped in, are you in fact referring that patient to another provider?
I really like the chronological order of the content. I think when we organize information in a logical, realistic way, it's easier not just to remember, but of course to apply in the clinic and utilize when we're trying to help our patients. And speaking of trying to help patients, I want to dive a little bit further into the results after you implemented this survey. And one of the skills you mentioned was utilizing evidence-based imaging guidelines. Now, I'm assuming most or all of our listeners have heard of a lot of this stuff, especially things like the Canadian C-spine rules, the Ottawa ankle rules, etc. But maybe people are a little bit less familiar with the appropriateness criteria, which I also use when I'm teaching and in the clinic. And specific to this point, I'm interested in knowing, how did physical therapists perform in this skill area? And is there a comparison of how they performed relative to their physician counterparts?
So the utilization of imaging guidelines is something that we've seen in the literature before, and we can start to look at some of these comparisons. And it's a little bit of a different way to look at it versus the appropriateness. Now, the appropriateness is the outcome. So the appropriateness is I referred the patient for imaging, I ordered the imaging, and when you actually look at the guidelines, it was appropriate for whatever reason, right? But that's a little bit more of a post hoc analysis of what's going on there. When we look at utilizing imaging-based guidelines, essentially that question is looking at more of an a priori question. So I'm going to make a decision on whether or not to refer for imaging. I'm thinking about the American College of Radiology appropriateness criteria, or maybe the Australian imaging pathways or whatever, before I make that decision. And when you look at the results that we found, 63% of physical therapists reported doing this routinely in their practice. Now, if you remember before, we talked about the appropriateness of imaging, and we talked about physical therapists were in the high 80s, low 90s for appropriateness. We talked about the physicians, at least in that Jenkins article, were in the 66-ish percent range. So now we're talking about physical therapists using imaging-based guidelines, 63%. So how does that compare to that, and how does that compare to what the physicians are doing? Well, when you actually look at validation studies for, the Ottawa ankle rules, the Ottawa knee rules, things like that, what they're finding is that, one, they've validated these rules, right? The Ottawa ankle rules, the Ottawa knee rules, things like that, they've been validated. And then when they go and they look at the clinical application of this, that third part, is this study actually being applied in clinical practice? At least on the physician standpoint, usually the guidelines aren't the go-to. The physicians tend to lean a little bit more towards their clinical decision-making process, their clinical intuition, if you will. And some of the research, I'm not going to go through all of them, but the research I've seen is typically talked about roughly 30-ish percent, 30 to 40% of physicians are actually using these guidelines over their own clinical intuition. So that would suggest that physical therapists, at least from an a priori standpoint, are roughly double of that, thinking about, what they want to be utilizing or what they want to follow as they're going into this decision-making process.
So if I'm hearing you correctly, then the current evidence says that we're already doing this, and that as a result, we, of course, as a profession, can jump into this role, and all the people that have some sort of potential stake in the topic can be confident, or they can rest assured that we're not going to screw things up. And I think part of the weight of what you just said comes from the fact that this was not just some small pilot study. As a matter of fact, when reading through it, your study is one of the larger peer-reviewed studies, or one of the larger peer-reviewed survey studies within the physical therapy publishing world. How did you get such a robust response, and what were some of the lessons, going through that process that you and your team learned about implementing this type of study on this particular topic?
Well, we had great help from the APTA, and specifically the APTA state chapters. So we focused our efforts primarily on state chapters, since the states are the ones that, Practice Act is decided at the state level. So they're the ones that have skin in this game. And, there are some states that, already have imaging that are looking to protect it. There are some states that are actively pushing for imaging rules or legislation. And then, there are others that might not be doing it, but they're, looking at it on the horizon. So we reached out to all the states, and they were a huge partners in helping us get this pushed out. So some of the lessons learned with this, so different states did different things. So some states obviously didn't participate. Some states put our survey on their website or their social media. When that happened, we got very little as far as response. So it doesn't seem that websites or social media is really a huge driver in regards to this, at least not from the state chapter standpoint. We also had some states that put it in their newsletter. We didn't seem to get a whole lot of response from those that were in a newsletter. We actually had gone through some of the APTA sections as well. So the ortho section pushed it out in their Ortho Bullets newsletter, but again, the newsletter just didn't seem to generate a whole lot of response. We did get a lot of response when organizations sent it out on direct emails. So if they sent it out to their members and said, could you please participate in this study? We got a very robust response from that. And AOMPT was actually one of the organizations that pushed this out directly through an email. We did see a substantial bolus of responses from AOMPT members. I think one of the other lessons we learned from this is, when reaching out to some of the state chapters, it was interesting to hear that some of them didn't have a process in place on how to do these things. So they might have had it for research for, a survey study on patients or things like that, but they didn't have it for things that was going to impact their legislative priorities directly. So it was interesting to hear the feedback on that, and that some of them were actually putting these things in place. And I think if going forward, if state chapters have something in place, I think they can actually get a lot of research pushed out through methods like this if they coordinate appropriately.
I've conducted a few surveys myself, and that sounds like a very complicated and detailed approach. So I'm really glad you took that rigorous route so that your results could be more, let's say, far-reaching and impactful for the profession. And in terms of those results, I know we've already partially touched on this, but are there any other major points that you want to talk about in terms of after you analyzed all the responses, what types of trends or tidbits here and there did you and your co-authors figure out when all the different findings were laid out in front of you?
Well, I think the biggest takeaway from this was how many physical therapists are already practicing these skills. So we talked before, there are 9 skills. On average, physical therapists were practicing 7 skills total, which already shows how much involvement physical therapists have in whole across the board. I think the other piece of this, and this is probably what's going to be most impactful to legislators and rules makers, is how many physical therapists are performing all 9. Because if you're not performing all of them, then that shows there's gaps and things like that. And our study found 28% of physical therapists right now today are performing all 9 skills routinely. So that shows that practicing of imaging skills is widespread. And 28%, how is 28% widespread? And you have to understand how rules are made and how jurisdictional scope and personal scope works. So just like most states allow dry needling, those that dry needle in the profession are still a minority of the profession. There's probably not a lot of PTs in acute care that are dry needling for infection reasons and things like that. So just like with surgeons, surgeons, not every physician is a surgeon, but yet surgery is allowed in the physician scope of practice. So you don't need a 100% saturation of people being able to use these skills. What you need to show is that a large number are in fact practicing this currently. That's what that 28% indicates. And then as other add on those skills, then that number will expand over time. I think some of the other takeaways we saw was in our interactions with various other variables. And, we had an idea of where we thought imaging was going to shake out and as being more commonly utilized, and those areas that weren't going to be as common. And orthopedics and sports clinics or therapists were where the skills were being practiced more commonly, which would make sense. Those that were on the more inpatient side of things like home health, acute care, SNF, rehab, they tend to not use them as much, which seems to make sense. I mean, you tend to have an attending physician that's easily accessible in those roles. And even myself, I've worked both outpatient and inpatient. My interactions with imaging were certainly different on the inpatient side. I think some of the other things we saw that were interesting as well, you hear a lot in the chat rooms that the DPT didn't add anything. Oh, the DPT was just an extra year and more, more money for schools and things like that. And, I've never been a big believer in that. And this data would shake out to suggest that there is a difference in what's going on. DPTs were utilizing imaging skills more commonly than both their MPT and BPT counterparts. And MPTs were actually using imaging skills more commonly or more imaging skills as compared to their BPT counterparts. So there does seem to be an interaction with education where more education leads people to be utilizing these skills a little bit more. That was further compounded by our results when we looked at residency and fellowship trained PTs, as well as board certified PTs. And both of those groups, if they were residency and fellowship trained, were using imaging more. If they were board certified, similarly, they were using those skills more. So there is a component of continuing education or advancing education that's tied to these imaging skills.
Thank you for making those points. They certainly add a deeper understanding to this topic as a whole. And as we're moving towards closing out this conversation, in terms of how you think things might unfold in the future, what can we, and I know I'm asking you to maybe predict the unpredictable, but what can we expect for the physical therapy profession as it relates to ordering musculoskeletal imaging in the U.S. as we go through the forthcoming years?
I think you're going to see states flip reasonably quickly on these. When you look at how many have just dropped in the last 6 to 12 months, West Virginia, Arizona, North Dakota, and Rhode Island, I think have all passed either rules or legislation in the last 12 months. I'm not going to out any states, but I know there are a couple of states that are currently working on this as well, that could be announcing it at any time. So I think you're going to see these states flip pretty quickly. Now, different processes take different amounts of time. So a board decision could take a very short amount of time if that's all that's needed. Board rules might take a couple of years. Legislation usually takes 6 to 8 years. And depending on what route is taken by the state, there's different levels of security. So while a board decision might only take a couple of months, maybe, that can very easily be overturned by either a board rule or a practice act or things like that. Versus, once things are actually in legislation, it takes 6 or 8 years to get there. But once they're in legislation, usually it's pretty solid. It's hard to overturn those. But what I would say is that those that are interested in getting a pulse of where this is in their state, the important thing is to make sure you're going through your APTA state chapter. Because if you do start the process on your own and you're not prepared if you're not asking the question the right way, or you're not pursuing it at the right level, so maybe your state needs legislation because what's currently in the Practice Act, but you're working at a board rule level, or maybe you start the legislation process, but you only need a board rule. Your state will have a pulse on all this in coordination with the imaging special interest group. And what I will tell you is if you partner with your state chapter, I'm sure they'd be happy to have your energy and your volunteer time, but they can help point you in the right direction and make sure that it's being done in a way that's not going to set back the process instead of moving it forward.
Those are all spectacular points. Thank you for making them. And I too will encourage everyone to reach out to the powers that be so we can move the profession forward. But that point aside, Dr. Mabry, it's been a distinct pleasure talking to you about this topic. Thank you for all of the imaging-related work that you and your colleagues have been doing for the profession. I also thank you for helping us follow up on this topic because we've taken a dive into it before, and it's interesting to see how things progress over time. So, moving forward, I wish you all the best of luck, and maybe we can have you back in the future.
Sounds good. Thank you so much for having me.
This has been a production of the American Academy of Orthopedic Manual Physical Therapists. You can learn more about the Academy by visiting our website at aaompt.org. You can also find us on Facebook, Twitter, and Instagram by searching for our acronym, AAOMPT. The views and opinions expressed on the AOMPT podcast are those of the interviewers and interviewees and do not represent the official position of AOMPT. The information presented should not be used as personal healthcare or clinical practice advice. If you need to find an expert orthopedic physical therapist near you, then check out the Find a Fellow feature under the Public Resources tab at www.aaompt.org, which you can find in the show notes.